Ladies and gentlemen, welcome again to this week's lecture. We apologize much for the delay in the technological difficulties, and at this time, I think we have wisely postponed Group 1's presentation for this evening. We'll be having Group 1 and 2's presentation on Wednesday of the 20th of May of this week. What I would like to do is to continue while people get on the live chat, is to continue in terms of the syllabus, is that I would like to focus on the clinical case conceptualization method and the mental status exam as per the syllabus. So at this time, it's going to be a new heading, and I want you to write for the new heading, the case conceptualization method. Incidentally, I also had lectured on the case conceptualization method from last year, so I'm going to have Mr. Nyame put that as a resource along with the Child Care Act of Jamaican Child Care Act for people to access as a resource.
It's up already that time. It's up already.
There's another one, the case conceptualization method. If you could also put as a resource that they can listen, since we had it was kind of truncated. It's much more longer, and that the way they can access that also. Okay. So let's also continue with the case conceptualization method. Everybody, that's the heading, and I will do my best to while we have the live audience and the live chat. All right. So basically, then, what is this case conceptualization? What it is, as we are preparing to do some treatment do treatment approaches and learning treatment approaches for children and adolescents. What it is? Can anybody, before I go into the lecture, tell me what they think case conceptualization is? For those people who are online or on YouTube can field questions. What is it? What do you think it is?
Well, Dr. Mark, I believe that in a case conceptualization, there are various areas that you will zero in on as it pertains to the case. So, for example, just one example, you look at the cultural aspect, you look at the issues that are presented, or what is presented in the case. You look at, well, I don't know if this would be applicable, but like, for example, in family therapy, you know, they look at boundaries and stuff like that, parental interaction and things like that. So it's various
techniques.
Various what?
Techniques.
I didn't get that.
Now saying various techniques.
Okay. I see Nardia saying that it is information gathering.
Yes.
Explain what you mean by information gathering, Ms. Crawford. Or anybody else on YouTube? What do you think? Anybody else? What it is? Anybody else? Anybody? Anybody else? All right.
Dr. Mac,
Yes.
this is Wanda.
Okay. Yes. How are you? Go ahead.
There's all the information. So I can't hear Dr. Mac. Whenever I speak, unfortunately, I can't hear. So
I am hearing you clearly.
The mic as soon as I'm finished to hear what you're saying. As I was saying, that it is gathering all information, using the factor of precipitating factors, purposive, all the information you can gather about the individual and the factors relating to that. And you, as a clinician, you will document all these things. And this information helps you to make an appropriate treatment plan for the client.
Okay. All right. Good. In a sense, yes. But case conceptualization is broader, specific, but comprehensive. Let me repeat. It's broad, it's specific, and comprehensive. In other words, when we are conceptualizing, we are I'm sorry? Somebody's saying something?
Victor, mute your mic for me, please. Victor, mute your mic.
All right, thanks.
Is someone saying something?
No, go ahead, Dr. Mac. Go ahead, Dr. Mac.
Yes?
I saw two comments, one from Renee and one from Elseda.
I haven't seen them at all.
Right. It says, Renee saying, I believe it is the therapeutic goals and strategies used to help the client. And Nordia says, understanding dynamics in the client relationship.
Okay, I just see it now being put. Okay, yes, it's
and Elseda is saying it is a clinical assessment of the client.
What do you mean by clinical assessment of the client, Ms. McDonald? Explain goals and strategies used to help the client. What do you mean by that? Anybody else? Could they, are they responding?
Dr. Mac, remember that it's a bit delayed, so by the time you speak, it take a while to reach them, then they would have to then respond.
Okay. All right, let me pause a minute while to get them to respond, and then I start. Could someone remind?
Hello?
Bonjour. I see Rhonda saying that they're not hearing anything.
I'm going to give them a link. No, I'm going to send them the link again. I'm going to close it into.
All right. Robert, Dr. Mac. Robert is saying that it is information gathering in order to make a proper and informed decision.
Yes.
Renee says within the conceptualization process, we may justify the various theoretical orientations, such as the various therapies, like Alderian, cognitive, etc.
Okay.
The reason is to diagnose the problem.
Okay, I see it here too.
Right.
All right. All are correct in a sense. All of you are correct, but let's look at it in terms of what it is. Now, as I said before, it's specific. It's very specific, but comprehensive. trying to remember what I said. Could someone remind me, please? I said specific. I said comprehensive. Did I say broad?
Yes.
Okay. Let me continue. So, when we're looking at the word conceptualization, we are making a formulation about a set of hypotheses. Let me repeat. We are making a formulation about a set of hypotheses. That is, we see, we observe it, we have to measure or assess it, and then we have to quantify it, to label it.
Can you say that again, Dr. Mark?
Observe, we're observing it.
Hold on, about a set of hypotheses?
It's a set of hypotheses. It's a set of hypotheses that we are making about, and I'm paraphrasing, about a set of behaviors that we are seeing by observing. We are seeing it by observing, and this observation is known as a sign. We see it, we observe.
Okay.
So once we observe and we see it as a sign, we have to quantify it and assess it. We are assessing it. We are assessing behaviors for us to justify a future outcome. Let me repeat. We have to assess the behavior to justify a future outcome. So once we assess this behavior, we have to put a label to the phenomena, behavioral phenomena. We are putting a label to the behavioral phenomena called a diagnosis. We are putting a label to the behavioral phenomena called a diagnosis. So once we have a diagnosis, we are moving from the realm of hypotheses into theoretical fact. We are moving from the realm of a hypothesis into theoretical fact based upon confirmation, by the DSM-5. Okay, the DSM says it. This is what I can. So in other words, this label means this in terms of categories.
So Dr. Mackey said we move from the
Yes.
diagnosis to a theoretical what? I missed that part.
We move from the realm of hypotheses to theoretical facts based upon
the DSM-5. In other words, we are going to confirm that hypothesis by the DSM-5.
Okay.
So diagnosis means that we are moving. We are labeling a cluster of behavioral phenomena through the scientific method. In other words, the DSM is really a scientific method of organizing behavioral phenomena. The DSM is a type. It's a type. In other words, it's a type of scientific method to give us to label a behavior in order for us to treat it. So once we have a diagnosis, we have to also have a prognosis. Is this behavior treatable? So if it's treatable, how we will treat the behavior? How are we going to treat it? By what means? What's the procedure to treat it? So we can use a treatment approach, and then how is this treatment approach going to manifest itself? That it's understandable and measurable. How is this approach that we are going to use, or intervention, going to manifest itself with this diagnosis that it's both measurable and understandable? That's called a treatment plan. Briefly, that's called a treatment plan. So, once we have a treatment plan will normally have a cluster of goals, an objective, and a problem statement. It will normally have a number of goals, an objectives, and a problem statement. The treatment plan, just briefly, normally leads to an attempt to resolve the problem. It's resolving the problem. It's resolving the problem. The treatment plan also helps restoration of the person. Restoration of the person to normal function. Treatment plans are time sensitive. Treatment plans are time sensitive. They have an end, and that is to terminate. So let's look at the method in a nutshell, basically. So case conceptualization has several features or several characteristics.
Dr. Mark?
Yes?
Norda is asking what is a problem statement in this case?
A problem statement in a treatment plan is what is the patient bringing to the clinical interview? Johnny has behavioral problems. Johnny has aggression. Johnny, teenager X is depressed and anxious. Teenager X has an eating problem. That's a problem statement. And that is usually known as a presenting problem.
Okay.
I'm going ahead of myself, but I'll say it anyway. It's normally known as the presenting problem or the presenting complaint.
Okay.
So I was saying that the case conceptualization method. Yes.
Sorry to interrupt. Robert is asking you, why are the treatment plan time bound?
Okay, I'm not seeing it. Mr. Nami, could I get the students' questions? I'm not seeing it at all. Okay, to answer Mr. Barr's question, treatment plans are time bound and time sensitive because the client's problem has to be resolved. The basis of case conceptualization is to come with a plausible diagnosis based on a presenting complaint, and in other words, you set a time frame in which you're going to solve this problem. So a treatment can range up to 3 months to 6 months to a year, and after that you have to disengage from the patient. You can't be seeing the patient forever. So that's what I mean by time bound. Is it clear, everybody?
Yes, Dr. Mark.
Is it clear, everybody? Other students? Okay, let me continue with what I have a definition of it, and it has several characteristics. One.
What's this, the characteristics?
Yes.
Okay.
It is a formal, comprehensive overview of behavioral phenomena. Let me repeat. It's a comprehensive behavioral overview of behavioral phenomena where there is an identification of a set of problem areas. Problem areas. There is an identification of problem areas. Again, it's known as a presenting complaint. That is, the patient or the child's caregiver will tell their story, or the teenager will tell their story as to what's happening. It's based upon what is known as procedural methodology. Let me repeat. It is based upon procedural methodology. That is, it is based within what is known as the clinical interview. The treatment, I'm sorry, the problem, the target problems or the problem areas is based within the clinical interview. The clinician is going to derive from the interview or from the story narrative of the patient a number of hypotheses. And these hypotheses will provide indication. These hypotheses will provide indication as to the nature, the severity, the nature, severity, and the function of the behavioral phenomenon. For example, the nature, function, and severity of the behavioral phenomenon, otherwise known as symptoms. That's what the client is reporting, and signs, what you're seeing. Severity.
With your mic, Eileen. Go ahead, Dr. Matt.
Okay. So the clinical interview is a very important procedure to gather facts, to observe behavioral phenomenon, and to determine the course of treatment. So I basically look at the features in a nutshell. Let's look at some elements of the clinical interview under the same case conceptualization method. Let's look at some elements of the clinical interview. I said it's a comprehensive process. It's a formal interview. It's structured. It's formal. It has to be structured. It has to be formal. There are certain identifiable questions. There are identifiable questions that are asked in a systematic fashion. The interview seeks to organize or organize and to get an explanation of large amount of clinical data being given. It seeks to organize, get an explanation, and to make clinical sense of large amount of data being presented that has to be quantified or reduced to a diagnosis. So, for example, James presented to the interview with his mom. Johnny has had a history of aggression, night terrors, peer conflict, poor attention span, and difficulty studying at school. That's a large amount of data, but you have to make sense out of it. So, based upon what I just said, the interview within that case conceptualization serves serves the clinician to make formal treatment decisions via a diagnosis, via prognosis, via treatment intervention / treatment plan for a particular client.
Dr. Mark?
Yes.
Are you still on the first characteristic? All that you just said is still a part of the first characteristic?
No, I should have, no, put for everybody, put under 2. I should have said I'm on a second point under that characteristic.
Okay,
element.
thank you.
I apologize.
Okay, thanks.
But just know that once you have a presenting complaint, it can be a whole. You can have a whole a paragraph. You have to reduce it and quantify it to make sense of it. When I make sense of it through hypotheses, I'm hypothesizing, but I have to make it factual through confirmation from the DSM. Once I do that, I'm going to determine under number 2, how am I going to treat this? What prognosis is this a waste of my time? Can this person be better? If this person can be better, then I'm going to determine what treatment approach am I going to use? Am I going to use transactional analysis? Am I going to use play therapy, family therapy? Am I going to use cognitive behavioral therapy? How am I going to quantify these problems that they're telling me into a treatment plan that is workable and I can measure it? And then after that, within 3, 6, or a year, they're gone, they're finished, they've completed treatment. So the third thing leads to the third element, which is you are going to have to document about your formulation, your diagnostic formulation. Diagnose the prognosis. into a written, it has to be written down, documented in terms of a treatment plan. So let's look then at the key components. Let's look at the key components of what is considered good treatment. Key components. It is its role primarily, underline the word primarily please, is to formulate a treatment direction. This is, as I said, this is a treatment class. It's not a psychopath, even though we have to diagnose. It's primarily a treatment. So if I'm going to treat, my treatment must be effective. My treatment must be comprehensive. And my treatment must be based upon empirical facts that once I treat, they don't have to come back. They're done. So it has to be empirically based. So in other words, what do I mean by that? You look for, so in other words, treatment approaches are mostly empirically based. They have good utility. So it's known that...
Dr. Matt, sorry.
Yes.
Yes. Where you said something about document your, and you didn't finish the statement. Document your and formulate your what?
You're gonna, I'm sorry, I thought I had made myself clear. You are going to document, once you have made that formulation of the problem that you heard and you quantified in terms of a diagnosis, you are going to document based upon the diagnostic formulation. You're going to document how are you going to treat it. So you document how you're going to treat it, and this is more treatable by goals and objectives.
Okay.
So you're going to once you have your problem, okay, let's give an example. I'm jumping the gun, but let's give an example. Johnny will reduce symptoms of depression. Teenager Y will reduce incidence of anorexia or reduce incidence of purging. How will I do that? As evidenced by participation in family therapy, as evidenced by participation in play therapy, as evidenced by participation in understanding the adult ego states of transactional. That's what I mean. Is it clear?
Yes.
Is it clear, everybody? Hello?
Yes, Dr. Matt.
Okay.
Yes, Dr. Matt.
Let's continue. Let's continue.
Before you go, Dr. Matt. Michelle,
yes.
On YouTube.
Yes.
She said, Dr. Mac, is the set out of the treatment planner book both child and adolescent?
I need to see the question. Can it be put on that I can see it, please? Visually, I need to see it.
There you go.
Tell her yes.
Yes, Michelle.
And incidentally, you need to go. I don't know if people have bought, as I said before, the books are expensive, so maybe it would be nice if you could use the old 1996 adolescent treatment planner, child adolescent treatment planner, because I know to buy them separately they have probably changed because of the DSM-5. But the DSM planner sets out it nicely. So you may, what I suggest that you do for the next case that you have is to look at the case and look at the treatment plan and how and look at how they set it out, and see if you can come up. What I want you to do for the next case is to come up with a goal. What is the behavioral problems? What is it that's jumping out to you? What are your hypotheses about the case? Age of onset. Yes.
Your students on YouTube seem not to understand something and asking you to repeat. But I'm not too clear what exactly they want.
I asked them what they want me to repeat. I don't know. I said a lot. I don't know what they want me to repeat. I answered Michelle's
question. They want you to repeat the example, Dr. Mark.
Example. I said a lot. What example? Ask them what example. Remind me of what example. I said a lot.
Something about the boy.
Probably about Johnny.
About Johnny, right.
Okay, I will have to just clarify. Okay, I mean I say the same thing over, but I'll just give an example that that basically and I think I may need to go to the case itself that I can do this. Mr. Diame, could you put that case up on the screen, please, if you can?
Which one?
The one on Justin that I asked for people to look at the one on Justin. I think it's important that we put it on the screen that people can understand and I can explain what I mean.
Okay.
Put the case on the screen for me, please.
While I get it, just continue.
Now, have persons looked at that case?
Yes, Dr. Mark. And I noticed the second or third paragraph.
Yes.
There's a part that says Jason was finally adopted by a family. I'm wondering if it's Justin you meant.
That may have been Justin.
That may have been an error. And then there was another section that you said, since living with Mr. Henry and Mrs. Catherine Watson for several months, the Watsons became concerned.
Okay, let's do this. Let me finish what I'm saying, that I don't lose my train of thought. Okay. And then I will once we have the case up, then I'll stop. So let me continue. So what I'm saying is that that basically what's happening is that when you're treating case concept, the clinical interview, within the case conceptualization, it is where you are trying to as I said, make sense of clinical data. And in making sense, once you have a diagnosis in which to treat it, you're going to be able to look at an orientation. In other words, what you're asking yourself the question, what suitable treatment approach can I use with this patient? So the child's developmental age or the child's level of maturity will determine what kind of approach you'll use with this child or this teenager. You have to take into consideration the child's cognitive development. You have to take into consideration the child's emotional maturity level. You have to take into consideration, what is the child level of the child's psychological functioning? So with a 5-year-old, would you use CBT with a 5-year-old?
No.
No, doctor.
I hear that a fervent no.
No.
I see a question here, and somebody's asking, will you be doing a treatment planning class in a particular case? Yes. Yes, everybody. I think it's important to do that. Yes, yes. Go ahead.
Back to that question, Dr. Mark.
I didn't hear that, Mr. Chiano.
That question has been responded to. We just sent the feedback to them that you'll be speaking on that.
Do you have a model case conceptualization we could use as a reference document? No, I don't. In the case, I will teach you how to do that. But let's continue. Okay, it's up. But let me finish before I do that. Can I allow me to finish? So when we look then at, this is the key. There are certain features you can use in terms of understanding the clinical interview and how to use it in the method. It's what I call the how, what, and when. Or the what, how, and when, I should say. What, how, and when. The what, how, and when. This is based upon the uniqueness and the integrative formulation for each patient. Every patient is different. They're not the same. The what, how, and when. So the what of it is. So the what of the case conceptualization method is the client is telling their story. Mrs. X, Johnny is, you brought Johnny. Tell me what the problem, how can I be able to say, what is the problem? So the parents for the child will be telling the story in the eyes of the parent. So the child can't articulate what's wrong. The child is acting out. It is asking the parent, what is the problem? What is the problem? So the what is the client telling their story. So in the case of a child, it's the parents. It's the legal guardian telling the story. This is known as symptom. It's symptom driven. The narrative of the child's problems is symptom driven. The narrative from the parent is behavioral driven. The narrative from a child is symptom driven. The narrative from the parent or guardian is behaviorally driven. The parent is reporting what is happening. Is the behavior externalizing? Is it internalizing? So it's externalizing versus internalizing of behaviors. Let me stop. Is it clear, everybody? Is it clear, everybody? Clear?
Yes, Dr. Mark.
Okay. The second is how. And the how is from the clinician's perspective. The how is from the clinician's perspective. That is, the clinician will quantify, theorize, hypothesize, quantify, theorize, hypothesize, any maladaptive behavior that are maintained, any maladaptive behavior that are behaviors that are maintained through an activating event or stressor in the family environment. So the how basically is any precipitating stressor that is causing this behavior to continue. When is more chronological in nature. When is chronological? How long has this problem been happening for? When did it start? When did you notice that he became aggressive? It started a week ago, 2 weeks ago. Time of onset. Time. So when has duration of the symptoms. So the symptoms, so duration means that the symptoms have evolved. They started a week, 2 weeks, a month ago. When is also linked to severity, symptom severity. Has a problem just started, where it's immediate, more acute, or has the problem still in perpetuating throughout a period of time where it becomes chronic?
Dr. Mark?
Yes?
Alison is asking, when we as clinicians see the behavior in the sessions, they are considered signs. So when we get report of the child's behavior from the parents, would they be considered sign as well?
Okay, can somebody put the question that I can see it, please? I prefer to see it visually. Mr. Nyami, can you assist in putting? Okay.
Here it is.
Okay, she's asking, let me read it again for people to see it. When we as clinicians see the behavior in the sessions, they are considered signs. Are they? Let me ask people. Are they? Are they?
Yes, Dr. Mark. Yes, Dr. Mark.
And why? Why are they signs?
Signs, because those are things you can actually see. You can actually visualize what is going on with the child.
Okay.
They're acting out.
Okay. So in other words, when you hear the presenting complaint, you are going to quantify that these are signs to you. So signs would be a child who is hyperactive moving from chair to chair in your office. Is that a sign or a symptom?
Moving from chair to chair is a sign.
They're jumping over the place. They can't sit still.
That's a sign of
paying attention. Is that a sign?
That's a sign of hyperactivity.
What would be a symptom from a child or a teenager?
I feel sad.
Or my tummy hurts.
Very good. Which suggests that you are now gathering facts. You are gathering okay, tummy hurts. Which symptom in the DSM will say with a child, tummy hurt? I feel sad. Oh, maybe mood. Is the child, is he depressed? My tummy aches. Is he having anxiety? Do you see the problem? You see the point? That's behavioral phenomena.
Yes, Dr. Ma.
Okay, so she's also asking, we get reports of the child's behavior from the parents. Would they be considered signs as well? What do you think? Or symptoms? Why would it not be symptoms, ladies and gentlemen? From Miss Allison's question, why would it not be symptoms?
My understanding of symptoms, Dr. Ma, is based on what the client themselves is reporting, what they are feeling. Anybody else apart from the client. So whether it's a parent, a guidance counselor, a teacher, the therapist, anybody else that is viewing the child and seeing a behavior, that would
Yes.
be a sign.
Okay.
And also,
So
Dr. Mark,
sign. Yes. Yes, Mr. Yes, go ahead.
probably because it's not observable, but it's something it is being related to within the context of the interview process.
You're losing me. Repeat.
I'm saying probably because it was not observed by the clinician. However, it was reported by the client or the child's parent as such. It's based on that.
So if it was reported by the parents, it's a sign or symptom.
It's a
It is a
symptom.
sign.
No, when
Why
it is
would it be a,
when it's been
Um,
reported by the caregiver, it is a sign, not a symptom, because it's not observable. You didn't observe it yourself.
okay? Let me be very. Go ahead.
Marshall is saying it would not be a symptom because it is not the client's report of himself or herself.
Yes.
And Nordia said, hold on. Nordia is saying that
Not, I'm saying that not because it's not the client's report, him or herself.
Right.
Headache, hearing voices. Headache and hearing voices are signs or is a headache or hearing voices a sign of symptoms.
If it is from the child, it would be a symptom, but if it is from the parent, it would be a sign.
Brilliant. I need a glass of wine. Very good. Yes. So be careful because you're going to, the clinical interview is going to give you information that you need to quantify. It's going to give you information that you need to categorize. So the clinical interview, you're going to get information from a wide variety of sources: medical, educational, developmental, school, family, and you have to be able to get all that data, organize it, make sense of it, reduce it, provide a diagnosis, prognosis, and to treat it. Is it clear? That's basically what it is. Is it clear?
Yes, Dr. Mann.
Is it clear?
Yes, Dr. Mann.
All right, so the when, let me finish the when. So the when then is linked to time of onset. It is linked to severity of symptom. It is also linked, it's also linked not just the severity of symptom, but the nature of the stress itself. And so we are looking at causation. Let me repeat. The when looks at causation. What are the indicators? What are the risk factors? What are the stressors that's causing this problem? So causation will lead to severity. Severity is coordinated or correlated. Severity is correlated with duration. How long has this problem been happening? So when the child comes to you, it is pretty serious. They have now moved out of this family homeostasis into the wider environment, and it's affecting everybody. It's causing impairment. It's causing distress. It's causing danger to other people. We talk about commerce. You remember we talked about commerce for the commerce for features That's when it's pretty serious. When the child or the teenager gets to you, there is a problem in the family dynamics. There's a problem with the child's function. It's beginning to affect other people, and so there needs to be stabilization and restoration. Is it clear?
Yes, Dr. Mark.
Yes, Dr. Mark.
Okay, so Miss McIntyre thinks it's not clear. She's saying, based on what we had discussed earlier, signs were only what the clinician observed. The symptom is from the description of the client, so the description from the parents about that, what they observed, that will be considered a sign. Thanks, it's clear now. All right, put up, Mr. Name, could we put up the case thing? I think that will solidify what I'm talking about. Could the case go up, please?
One moment.
Yes. Please. And while he's putting the case up, let me just look then at the a new heading, and I just list, but I won't elaborate. I just list now what the case is up. All right. So you have read the case. Everybody read the case?
Yes, Dr. Mark.
Okay. Pretend that this 9-year-old boy came to see you in practicum. You have done, you're doing child and adolescent therapy. You've done, most of you would have done the psychopathology. Let's go through step by step the case conceptualization method. Tell me what is the age of onset? How would you approach this case?
Age of onset, Dr. Mark?
So yes, what's the age of onset? The age of onset, ladies and gentlemen.
From 2 years old.
2 years old, Dr. Mark.
2 years old.
Yeah,
Dr. Mark.
Okay, so we look then, so in a case, in a child, a teenager, adolescent case, we are looking at demographic information. Justin is a 9-year-old boy who was referred to the counseling center due to increasing behavioral problems, aggression, and with his peers at his school. What do you see from that? Tell me what you see. Tell me what are your hypotheses. Just tell me what your hypotheses is. Go ahead.
Attachment issues.
Okay. What are you noticing? Before you go on, Ms. Smear, what are you noticing, ladies and gentlemen, about the child's environment? Is there impairment? Is there distress to other people?
Yes, Dr. Mark.
Yes, Dr. Mark. And it was very unstable because he moved from home to home.
Okay, we're looking at the first 2 lines. That's all we're looking at. We're not going any further. The first 2 lines is what is an introduction. It's a demographic introduction in the clinical interview. This is what is, in other words, this is the referral question. This is known as the referral question. So the demographic info is really the referral. It's saying to you, he's 9 years old. He had been referred for treatment due to increasing behavioral problems, aggression. Do you see any behavioral phenomena? Do you see any behavioral phenomena? Do you see any target problems? Do you see any presenting complaints?
Yes,
the aggression.
Aggression.
No, answer my question, yes or no. I'm making it close-ended. Do you see any behavioral phenomena in the case?
Yes, Dr. Mark.
Yes, Dr. Mark.
Okay. So we are inferring then. What can we infer from this little 2 lines? We haven't gone any further. What can we infer from this referral question? They're asking you, This is what's happening. Help us. We are in the trouble. Don't say who referred him, but we do know that his behavior has spread into the out of the home. Am I correct?
Yes, Dr. Mark.
Yes, Dr. Mark.
Okay, so it's
Michelle is asking you a question. It's on the screen.
Okay.
Are you seeing it?
Yes.
Okay.
Okay. I'm doing this line by line is because I'm trying to at least show you based upon what you have been talking about in terms of how to deal with the case conceptualization method, provide hypotheses, come up with a diagnosis, come up with looking at time of onset, age of onset, duration, and then we are going to be looking at how to treat it. That's why I'm going through this in this teaching moment. When you're doing your own cases, you don't necessarily have to do it line by line, but at least you have the basic understanding of how to do the case. That's what I meant. That's why I'm doing it like this. So you can answer if it's clear to you or not. Anybody?
Dr. Mark, remember there's a delay on YouTube, so she has to, by the time you finish speaking, she's just hearing what you're just saying.
Okay. Well, I'll continue, and then she can answer. But basically, so this is the first two lines is the referral question. So the second paragraph justifies some of the hypotheses from the clinician's perspective. It says he suffered from traits of fetal alcohol syndrome. Is there a developmental issue in this case?
Yes, Doctor.
Yes, Dr.
What is
Mark.
it? It's what? What are the indicators that I talked to you about? Rotter's indicators. Is there Rotter's indicators in this case?
Yes, Dr. Mark. That
What is the Rotter? What is the Rotter's?
Maternal.
The teratogen.
Teratogen. Good. Very good. So a teratogen. So in other words, is there time of onset in this case?
Yes, Dr. Mark.
What's the time of onset?
I think it's from they were in the womb.
No, as in the video, as in the case, you don't have to go on. This is what you're seeing, this is what you're getting. It says he suffered from traits of fetal alcohol syndrome when he was a toddler. What's the time of onset of this problem? So toddler is linked to continued behavioral problems, aggression. Is it precipitating or perpetuating or predisposing or protective?
What, the aggression, Dr. Mark?
No. I'm saying he has suffered from traits of fetal alcohol syndrome when he was a toddler. We now know that the current behavioral phenomenon has been linked when he was a toddler. I'm asking you, is it precipitating, perpetuating, predisposing, or there are absent, or there are any issues with protective factors?
I believe the fetal alcohol syndrome would have been a predisposing factor.
Yes.
I didn't want to hear you. Do what?
I said that the fetal alcohol syndrome would have been a predisposing factor.
Yes, but also what other factors are there? It suggests other things. Look at the problem. He's 9 years old. So a 9-year-old span suggests what else? That the problem has been what? The problem has been
precipitating.
Beg your pardon?
Precipitating.
Precipitate.
No. Yes. The problem has been perpetuating. It's 9 years, he's a toddler. A toddler may mean 1, 2, says 9 years of this problem.
Continuous.
Okay. So it's continue. Any other Rotter's indicator? I'm trying to get you to be able to formulate. We are doing a formulation of, we are hypothesizing. Are there any Rotter's indicators?
Yes, Dr. Mark. One of the indicators is that he's out of the home environment. He's out of his own, the original home environment where he and his mother would have been, because he has been abandoned.
Yes.
Then out of home environment. That's one of the Rotters.
Okay, let me stop here. I see where people are asking some questions from the YouTube.
Yes,
I want to leave them out. Just a moment, please. I'm not certain. I will not be able to follow a structure in the way that you would like. Line by line is okay, but I believe that you give a proper plan. Would you understand how we'd like it? And that is what I want to ensure for future classes. So I will answer that. And Ms. Crawford is saying age 2. I suppose I'm not certain what that means. And someone is also saying predisposed. I'm not certain of the other responses, but okay, I will clarify for somebody who's asking about the case. What I'm doing is that I'm going through the method step by step with people, and then we'll arrive at the treatment process and we'll arrive at the termination process. But I'm doing it step by step. That's why I'm doing it. I'm doing it now, taking it piece by piece. So far, what are we hypothesizing? We are hypothesizing what? That this young man has had a developmental trauma since as a toddler, and as a result of over the years, his behaviors of aggression and behavioral problems based upon this behavior, this predisposing factor, has created a problem that is now coming to you for treatment. Do you understand so far?
Yes, Dr. Mann.
Is it very clear?
Yes, Dr. Mann.
Apart from that predisposition, we are now seeing where there is perpetuation of the factors, of the risk factors. We are now seeing that there's precipitating factors because he has the issues of what? Security, safety, and stability are not in the picture. Are we clear on that?
Yes,
Yes,
Dr.
Dr.
Mann. There are some comments from YouTube as well.
Okay,
Yes.
let me see. Okay, placement of the child outside of the home. Symptom from caregiver, but sign from child. Not certain if they can clarify exactly what they mean. But let me continue. So we now see that in terms of Rotter's indicators, the child has been placed outside of the home. Are there any attachment issues, ladies and gentlemen? Yes or no?
Yes, Dr. Mann.
Yes.
Are there any attachment issues? We don't see, but
Yes,
we can infer. So we are inferring, we are hypothesizing that based upon Rotter's indicators, based upon developmental issues, trauma, that this may be the cause of his current behavioral problems. Do you see that?
Yes, Dr.
Do you see that? We don't see why it's impacting peers at school.
Yes, Dr.
If we know that fetal alcohol syndrome, if we understand it, it's where the baby in the first trimester or the first several weeks of the trimester, the child's the frontal lobes will be impacted. So the child's so fetal alcohol syndrome is where the structures of the brain are compromised. So the child is impulsive. The child will be impulsive. Child will be not just impulsive. The child will have emotional difficulties. Child won't have there will be cognitive deficits. So we can look from that to say that possibly he can learn, he can concentrate, he can focus. Do you see that?
Yes, Dr.
This is what we're hypothesizing from his case. So if he can't focus, he's going to act out.
Yes, Dr. Mark.
Is he externalizing the problem or internalizing the problem?
Externalizing, Dr. Mark.
I beg your pardon?
Externalizing.
How do we know that? Where's the evidence?
Because he's aggressive.
And these are what? Externalizing problems. Okay.
Those are signs.
All right. Yes. Are they signs or symptoms?
Signs.
Good.
Right.
Okay, so.
Dr. Mark?
Yes.
Allison is saying he has had high factors and low protective factors, therefore high risk factors.
I need to see her question. Okay.
There it is.
He has had, is it Miss Crawford or somebody? Is it
Allison?
Okay. He has had high, okay. Yes, you're correct, Allison. Good. So let's continue. So based upon the fact of the instability in the child's life, insecurity in the child's life, lack of safety, he had been placed in the CDA. And so he had been placed in foster care. Do you see that for several months?
Yes, Dr. Mark.
So do you see, are there anything to note in the case? So so far we are building a number of presenting complaints. From 1 to 3rd paragraph are presenting complaints. Presenting complaints so far. Mr. Nami, could you make the let me see, up to the 4th paragraph, please? Good.
Robert is saying he's acting what he's feeling.
Tell him yes, that's correct. So from the 4th paragraph, we have the presenting complaint. Now, this is what we call gather the clinical data. And so when I'm talking to you, let me look at the task and processes of case conceptualization. So this is a heading, and I'm talking from a case to make it make sense to you. So you start the heading, task and processes of case conceptualization. That's a new heading, task and processes of case conceptualization. So in the sense of this case, from 1 to 4, you are gathering the data. You are looking at the presenting complaint. What it is so far it's 4 paragraphs. In this case, it's 4 paragraphs. Gather the data. The second is that in the 4 paragraphs, you are defining what the problems are, the presenting complaints. And so far, we can all infer that from as a toddler, he has been diagnosed with fetal alcohol syndrome. He has had some very severe Rotter's indicators. He has has been an absence of protective factors. There's some perpetuating difficulties and precipitating and predisposing. And so this young man had to be placed out of the home and in foster care with a new set of caregivers that he has to adjust to. Do you see that? We are hypothesizing. This is what we're doing. So we are looking at this is a presenting complaint, and so we are defining what the presenting problems are. So what are the presenting problems? Let's look at it in terms of 2. Define the presenting problems. What we're looking at in the case, we're looking at what is causing this child's behavior. What is causing this child's aggression? What is causing this child's behavioral problems? Do you see that?
Yes, Dr. Mark.
So the what of treatment, what? So we know the time of onset, start as a toddler. Do you see that?
Yes, Dr. Mark. Yes, Dr. Mark.
We see the duration of symptoms of onset, 9 years. Do you see that?
Yes, Dr. Mark.
We see age of onset as a toddler. severity of symptoms, he is now affecting other people. There is distress, there is impairment, there's danger. Do you see that? Do you see that?
Yes, Doctor.
Yes, Doctor.
Okay, so all right, so let's look then at what I'd call the other collateral information in the case. So the Watsons had another child, age 12 years old. So Justin was often jealous of his adopted siblings, and he would get angry, scream, and yell when his mother would pay attention to her oldest child. You also said the question when you hear this information. This is a narrative you're hearing from the Guardian. Is this normal? Is this normal behavior? Is this normal behavior?
No,
Not when
Dr.
to get angry and scream. So no, Dr. Ma.
Why not? Why is it not normal?
Because of the part that says he repeatedly.
In what?
The section that says he repeatedly lied, stole, and hoarded food. So I'm saying that normal behavior, children will lie from time to time, yes. But if he's doing it repeatedly, then that's when it becomes abnormal.
Okay, you're jumping the gun, jumping ahead of me. I was on the fourth. He would get angry and belligerent when he was let me see. I'm on the. He was jealous. He was often angry, scream, and yell. Now, being angry, screaming, and yelling. Is this based upon the predisposing factor, or is it based upon just recent events? You have to be able to look, get the and make and you're inferring. So you're looking at how each paragraph joins together. So the child, he's angry, he's screaming and yelling when his mother would pay attention to her oldest child. What is that suggestion you're saying?
Dr.
Yes.
Dr. Ma?
Will it be that based on the interaction that is going on in the family, as such is perpetuating, becomes a perpetuating factor that makes him to become more aggressive and upset?
What do you think, Mr. Chiana?
I think it's perpetuating based on the perpetuating factor.
Mm-hmm.
Yeah, that's what is triggering his aggressiveness towards his other brother and so on.
Okay, there are two questions here from the youth. Yes.
Oh, it's okay. I was about to read the questions for you. From Marshall.
Someone is asking. Yes, I'm going to read it. Can you please make age and time of onset? Age and time of onset. You used the two terms interchangeably a while ago. Okay, I wasn't aware I did that, but let me explain. In relation to the case, you're not the same. Age of onset is the age of onset is the chronological period in which a behavior starts. In the case of Justin, it started when he was a toddler. So in terms of determining for your diagnosis, it's very key in being accurately diagnosed. So if we're looking then at, for example, in this case, we have inferred about an attachment. Attachment problems start as early in childhood. So in this case, we can look at that this is an insecure attachment. So age of onset in a case is actually when a disorder started. This is primarily for diagnostic purposes, for you to go to the DSM and say, okay, the DSM, in this case, he started as a toddler. So in other words, what particular disorder am I going to look in the child with disorders to determine why this child is behaving this way and how am I going to treat? So seems to me that since I suspect he has an attachment problem, let me go and check the reactive attachment disorders and the attachment disorders in the DSM and to clarify from the DSM whether or not the DSM collaborates what I'm seeing here or what I'm hearing and seeing here. Somebody is asking, and I hope that answered the question. Time of onset for both Michelle and Marshall, time of onset, it's when a disorder actually started. It's the time frame in which a disorder actually started. Is it a 1 month? Is it a week? A day? This time of onset will determine exactly what the nature of a disorder it is. In other words, it will determine whether or not it's, for example, in a depression, in a depressive disorder, in a major depressive disorder, time of onset for a major depressive episode, that means the first time you have a major depressive episode, that has to be 2 weeks, but less than a month. So a depressive disorder will have to start at least for the last 2 weeks. I've been having symptoms of sadness, poor appetite, but it has lasted less than a month. If it's a major depressive disorder and it's recurring, it means that there was initially a first episode, but it is continuing and it's going to be over more than 6 months. Another example is that in an acute disorder or versus PTSD, in an acute disorder, it has to be less than 6 months. That's time. So if it is less than 6 months, it is not PTSD, it is an acute disorder. If it is PTSD and it's more than 6 months, it means that it's more severe in nature. That's time of onset. Okay, she said she's still a little confused between time of onset and age of onset. Are you still confused now?
Remember the delay, Dr. Max, so they would not hear your question yet.
Well, okay. I repeat it again. Are you still confused by time of onset and age of onset? All right, let's continue. What's that?
They're answering.
They're typing.
Okay. I'll listen, watch out, and then I get back. So, do we get so far? So, first of all, in the task and processes of case conceptualization, we have gathered the clinical data, we have defined the problems. So, can we now, for the third, provide a diagnosis for this child?
Dr. Mark?
Yes.
Michelle is asking you, so what is the time of onset in this case? In this particular case that we're reading?
Can somebody help her?
Dr. Mag, I don't think that time of onset would be applicable in this case. I think we already established that the age of onset was 2.
Yes.
So I don't think this would be a case for time of onset.
No, but okay, all right. So maybe I can see why she's confused. So the age of onset is when the behavior actually started. Time of onset is the period in which it got worse. It's a period in which the actual behavior from the age it started got worse. So for him, time years it took to become serious. You know, it got worse over time.
Marshall was saying that you use the definition of when or period disorder began.
When? Yes. It began at 2, and it began at 2 when in this case when the child had was diagnosed with fetal alcohol syndrome. So therefore it's the when. So as I said before, I'm just trying to figure out if they I'm seeing here. Hold on, I'm seeing here.
Some of them are confused. So
I'm a bit confused. They're asking about presentation. I'm confused. Okay. Let me try.
It's the right thing, but it's
okay. I'm gonna make this. I'm gonna make this this comment. I hope the YouTube people would have understand now the difference between age of onset and time of onset.
I think Michelle was saying she still don't really understand.
Okay. Michelle, could you type and explain again what is that you're not understanding? The people in the live chat, do you understand?
Yes, Dr. Mark.
So the people in YouTube, if you let me know if you still are confused about time and age of onset.
Michelle is saying, Dr. Mark, would that then be 7 years for time of onset?
In terms of what? We have to make it in terms of the case that it's clear. Let me see. For example, Marshall had her headache at age 5 years old. I'm not, hence the age of is 5 years.
Somebody was trying to explain it for them.
Okay.
All right, Marshall is understanding, Dr. Mark.
Okay, but I'm concerned about Miss Michelle. Is she still understanding?
Listen, Dr. Mark, Marshall is saying her my understanding is that they keep typing and it keeps going up. Is saying that her understanding is that the age of onset is a definitive age. Example, yes. When the disorder started.
Yes.
That's correct?
Yes.
Okay. So give us an example now of the time of onset.
Give a what?
I'm asking you now to give them an example of the time of onset.
Okay, the time of okay. Yeah. Are they understanding about the age of onset? That is definitive.
Yes.
It does not change. It has to be in terms of for diagnostic purposes. Do they understand that? Do you understand that the age of onset is definitive? It has to be for diagnostic purposes. Time of onset is the duration of, or the period. It's the duration of period in which the symptoms actually start, in which the symptoms continued over time.
Okay.
No, okay. Michelle, the time of onset in this case would be 9 years old. Or we could infer that it's over 7 years old, or it's probably 9 because as a toddler is what? Maybe 1 to 2 years. So if you want to look at the toddler as 1 year or 2 year, yes. So, but we're looking at it over 2 years. In other words, the problem started, and so the time of onset is when the time of onset is really linked to severity of symptoms. That the symptoms over time, over a longer period of time, got worse, got more severe. So in this case, the time of onset in this case would be chronic. Do you see that?
Would be what, Dr. Mark?
in this case of Justin as a toddler, at age 9, the symptoms would have gotten worse over time. So in other words, the symptoms for in this case where the time, time is linked to how long the problem is going on for. So in this case, he was diagnosed with fetal alcohol syndrome, and as time went on, and there are other stressors that came about, he started to develop much more symptoms. So he no longer has fetal alcohol syndrome. Has developed an attachment disorder, and he is also developing other problems.
Okay. So Michelle is trying to find out if she's getting the understanding. So she says, is the time of onset, in this case, 7 years? 7 years, oh gosh. 7 years, that is 9 years old and starting from 2.
Yes.
So in the case,
tell her
it
yes.
started from 2 years old. Yes, Michelle. Okay, doctor, you can continue.
Okay. So the third now is the case is gone. I'm not seeing it. Can we put the case back up, please?
Okay, that's
We may have to wrap up in about 10-15 minutes because it's so in the third instance of the task, and we're going to now provide a diagnosis. In this case, when we're providing diagnosis serves two purposes or several purposes. One, diagnosis seeks to clarify. It seeks to clarify one's hypotheses. It's clarifying. It's confirming by going to the DSM to support your hypotheses. You're clarifying the data. You're saying this is what, in other words, once you're clarifying, you're categorizing it. Once you're clarifying, you're categorizing the data, you're quantifying it, okay? This means then that it's probably an attachment problem this young man is having. An attachment problem. He probably has a mood problem. I suspect he may have a mood disorder. I suspect he may have a learning problem. And so we are making these categorizations. So diagnosis, it clarifies, it confirms. It confirms. And so once we confirm that these clusters of behavioral phenomena, we are going to go, the DSM-5 will highlight or will suggest that what we have come up with is true because it's verifiable. So we are clarifying, we are confirming, and we are actually and then we are verifying it is true. It is no longer a hypothesis, it's a fact. It is an attachment disorder, and in this case, it's a reactive attachment disorder. Does someone have a DSM? Does someone has a DSM in front of them to look at the diagnostic criteria for DSM for reactive attachment disorder? Does anyone have a DSM open in front of them? Does anyone have a DSM? No DSM?
Not in front of us, Dr. Mark.
All right. Okay. Basically, I wanted to have made it from the horse's mouth and not from mine, because my brain is shutting down pretty soon. But that in an attachment disorder, there is one of the main criteria in an attachment disorder is that that there is a difficulty in functioning, where the child has difficulty with dealing with relationships. So there is going to be in a reactive attachment disorder, there is going to be problems with hypersensitivity. Just trying to remember from the DSM, there is going to be problems with. Yes.
What exactly you want from the DSM, Dr. McNord?
I need to look at the diagnostic criteria for a reactive attachment disorder. We are providing a diagnosis. We are as I said, the data, we are trying to make sense of it, and we're going to give it a label. One of the label is a reactive attachment disorder.
Reactive
Could
attachment.
you read? Okay. She's oh dear. Could she? What are the criteria? It's a pity somebody doesn't. Read it. Nobody who is online, who is live, have a DSM.
I'm checking it out.
You're checking it out,
No.
Ellen?
I am trying online, but I'm not seeing it.
Okay, you won't.
Not coming up.
I have to read what's in. All right, I tell you what. It's after 11. I think I'll need to tackle this some more on Wednesday. What I want to do, everybody, is I'm gonna finish this and then we have the 2 presentations. I think that's what we'll do. So we're gonna have to stop because I need people. Please bring your DSM-5s to the class on Wednesday, please.
Okay, Dr. Mac.
Please bring your DSM-5 to the class. We're going to go over the task. There are 8 processes for the case, concept, uses, and method. And I want to go through them with this case.
Okay, Dr. Mac.
So bring it. We're going to look at the case concept. We're going to look at the interview with the child. Do as much as we can, and with the presentation. So we do the best we can. But please bring your treatment. Not your treatment plans. You can also bring your treatment plans and also bring your DSM-5. Treatment plans, DSM-5 to the class, and we're going to continue with this case. Okay, she's saying that rarely criterion A, inhibited, emotionally withdrawn behavior towards adult caregiver. Is there any evidence in that video about being, in terms of the diagnostic criteria? Is there any evidence? We are now looking at the DSM to confirm that diagnosis or confirm to see if it's a fact. Do we see any evidence of withdrawn behavior, inhibited, emotionally withdrawn behavior in the vineyard?
Yes, Dr. Mark.
Okay.
Because it said that, I think there was a section that said that Justin was never affectionate. Okay.
So we're seeing that. We're seeing rarely or minimally respond to comfort when distressed. We're going further. We're seeing persistent and social emotional disturbance by at least 2 of the following. So basically, we are getting the sense that this child has not only has the child has past symptoms of fetal alcohol syndrome, the child has an attachment problem that's causing this problem. So we now know that the reactive attachment disorder is a part of the aggression and the behavioral problems that is impacting people at school. Do you see that?
Yes, Dr. Mark.
Okay, so we'll continue on Wednesday with this. I want to do this first thing that I can get this out of the way, and we can get to how to treat this case.
Okay.
All right, so please bring your treatment plans and bring the DSM-5.
So the lecture will be first, Dr. Mack, and then the presentation.
I think we need to do that. I really do think so. I think I'm gonna have to try and figure out to do this. Because I need to go through the child interview, and I need to go through the interviewing parents and also all that. So I will come up with a way to see how we can maximize the class. I know we are behind the present because of what happened tonight, but we'll try and work something out.
So Dr. Mark.
Yes.
You said that each presentation should be the presentation should be 1 hour each.
Yes.
Okay.
Preferably, yes. Yes.
All
Take
right.
your time. I'm not rushing people. I just needed to be mindful that I'm trying to figure. I'm gonna have to talk to Mr. Nyami to see how we can get this maximized with 2, because we have 4. We haven't started yet, and we are a bit behind. So we'll see what we can do to get this done.
Read the case, Dr. Mark, for the group. For the group.
Yeah.
Is that something that we'll have to come and present, or is that paper that we need to do?
What are you talking about?
The group case that you sent us, and we have a group learning thing.
No. We can. The group case is going to be. You're going to prepare it and give it to me.
Okay.
The cases I sent you are for practice in class.
Oh. Okay, Dr. Mark.
All right. I think we're going to end here, ladies and gentlemen, tonight.
Okay, Dr. Mark.
We want to continue with this. We have to continue with this. Very important. So I'm going to be still on 3, providing a diagnosis. I'll try to finish all 8 task processes on Wednesday, God willing. So I'm going to talk to Mr. Nyami. Mr. Nyami can remain for a couple minutes to see what we can do, or Mr. Nyami, can we talk another day, or what can we do to discuss how we're going to get these cases out of, these presentations out of the way?
We'll talk tomorrow. Let's make a talk tomorrow.
At what time?
4. Wait, what time tomorrow? 4:30 my time, or 5?
Can we do it a little later?
I have a meeting on Tuesdays at 7, and I have to go to it. So that's why I was saying 5 or so.
I'll be out tomorrow. I'm coming back in. Unless you want me to. What time do you finish your meeting?
9 o'clock.
I'm asleep by then.
Yeah, I figure. Should I stop broadcasting now? Let me stop broadcasting.
Yes.
No, wait.
No? Okay.
Dr. Mark.
Yes.
Michelle is asking if the lecture for Wednesday will last for 1 hour.
I will try to make it as well. This is what I'm going to plan with Mr. Nyami to determine how we're going to do this, and that we can maximize. This is a very important topic on the case conceptualization and treatment. I wasn't expecting to have two presentations, and we're going to see how we can do this. What I suggest, ladies and gentlemen, on your syllabus, we have the child. What's it? My brain is shutting down. Let me see. We have the Child Care Protection Act. There is a lecture I did on that. Please ensure that you listen to it. And I think there is also another lecture I did on the case conceptualization method for another set of students last year. please also listen to that between now and Wednesday.
Okay, Dr.
I think also we're going to be opening up this week's for the you're going to do your discussion forum again. I'll be opening it up as soon as possible with Mr. Nyame, and it's going to be due on Friday again. Since you're going to be having the class on Wednesday, it's going to be due Friday and Sunday of this week.
Is this a last
clear?
discussion post, Dr. Mark?
I think there's one last one next week, but I'll have to go back and check. I think there's another one next week. There are 4 posts.
Dr. Mark?
Yes?
Michelle is asking you, what time can she call you tomorrow morning?
Okay. So I'm not going to work tomorrow, so she can call me around 9 o'clock my time, 7 her time, whatever. 9 my time, 7 her time.
Okay, Dr. Mark.
Or ask her when she's at work, she can call me. No, because I'm going to be taking up with a call tomorrow. At 11 my time, so she may want to call me either when she's at work, which is 10 my time, 8 her time, that I'll be up.
Okay, she's hearing you, Dr. Mark.
Okay. All right, ladies and gentlemen, I apologize again for the technical difficulties and the glitches, but we have managed to have a class, and so I think is this case helping people? Is the case helping?
Yes, Dr. Mark.
Other students, is the case helping you? Is this case helping?
Yes, Dr. Mark. Yes, Dr. Mark.
We'll finish up and we'll continue. I'll talk to Mr. Nyame about how we're going to get the presentations out. That's important, and to get the class, maximize the class. So we'll find a way.
Dr. Mark.
Okay, Dr. Mark.
Yes?
Dr. Mark.
Yes.
Michelle is asking if we'll be getting any feedback on the discussion forums.
Tell her I will not, I probably will do for one set, not for all.
Okay. And she said she'll call you 5 her time and 7 your time.
Tell her I'm still asleep.
Okay. Okay, Dr. Mark. Good night.
Bye.
Bye.